So I'm going to introduce our first panel member, okay? I'm going to butcher her name, but I've been trying very hard. Dr. Ayoka Gaba. Saidi is a senior project director at the University of Massachusetts Medical School, Department of Psychiatry. She is a clinical psychologist by training, specializing in the treatment of co-occurring mental health and substance use disorder and COD treatment, research, and evaluation. In her home at UMMS, Dr. Gaba directs the evaluation programs of implementing an evidence-based integrated treatment approach to address co-occurring mental health and substance use problems, and that is called Project Mission. Okay, so I'm going to have Dr. Gaba come up now. By the way, some folks are going to be doing their presentations right at the table. Some are going to have PowerPoints, so flexible like that.
Hold on when I deal with these tech issues. Okay. Seems like. Maybe go back. Okay. So, good afternoon. Thank you, Chris, for inviting me to be part of this esteemed panel of speakers. And it's nice to hear that there are a lot of providers in the room, and I hope this can give you some lessons learned that we've learned from our work to take back to your organizations and the work that you do and the clients that you serve. Today, I'll be discussing some of the clinical, organizational, and logistical challenges we face as we've been implementing a project for working with homeless individuals with co-occurring mental health and substance use disorders. This is a grant-funded project. It's funded by SAMHSA, and it is a collaborative project with, It's a collaborative project with Massachusetts Department of Public Health and also University of Massachusetts Medical School, some local shelter and supportive housing agencies and providers in the Boston area. So I will start with the problem statement. So we know that 50%, at least 50% of homeless individuals have a co-occurring disorder, meaning a co-occurring mental health and substance use disorder. They also experience a complex web of different medical conditions that put them at higher risk for relapse, higher utilization of emergency care services, and also impact their recovery. What we found when we were sort of working with this population is that many of the medical conditions were strongly associated with the substance use disorder. So, you know, the use of hypodermic needles and sort of increased risk for getting other diseases was also part of what we interacted with in this population. And then also we found that many of the folks that we were working with are in many different silos. So they're receiving care. They're receiving care in mental health agencies, substance use agencies, some of them in the criminal justice settings, medical settings, and there was a lot of fragmentation of care. So those were the problems we were facing when we initially launched this project. So to address sort of these different issues that our population was facing is that we implemented the mission model. The mission model is an evidence-based, manualized treatment to address co-occurring disorders. It is, we have a version of the model that is for homeless populations, CJ populations, and vet populations, and as we know, a lot of those populations intersect. The model integrates 5 different evidence-based practices, and I'll just walk you through quickly some of these practices. The first is critical time intervention. Critical time intervention is a form of case management where services are provided at a high intensity at the beginning of the intervention, and they over time gradually decrease as clients become more autonomous and more transitioned into the community. And that's provided, that sort of is a framework that goes over our whole model, that in the beginning of treatment, clients are seen at least 4 times by people on their team. Another piece of our treatment model is that we integrate dual recovery therapy, which the research shows that for folks who have a co-occurring disorder, it's really important to integrate both mental health treatment and substance use treatment in a seamless way where they're receiving the same care from the same provider. So here our case managers are providing dual recovery therapy, which are structured sessions that focus on things like relapse prevention, cognitive distortion, using CBT techniques, using some motivational interviewing and motivational enhancement techniques in treatment. And then the third core service is peer support. We have peer support specialists as equal members of our care team, and they work with clients by providing a semi-structured peer intervention where they meet for weekly sessions, which are focused on many themes that are related to recovery. They also provide transportation. They provide recovery supports. They might attend sessions in the community with the client, so they might go to a medical appointment with the client, they might take a client to AA, and they also do schedule with our full group of clients recovery-oriented activities. And I'll just go over on the other side, we have support services, the first being vocational educational support. Many of our clients are coming to us with very little vocational history or history that is not setting them up for success in the vocational or educational realm. So we do provide assessment of those needs, and then we link out to different supports for those needs. So we've used supported employment agencies to work with some of our clients, and our case manager and peer will coordinate that relationship. Last is trauma-informed, and I hate to put that last because it really is an umbrella under which our whole program is based. So we acknowledge that the majority of our clients are going to come in with a very significant, and for our clients, very complex trauma history. So everyone on our teams are trained about trauma-informed care, making sure that they are fostering an environment of safety, fostering an environment where there's transparency, and also referring out when trauma treatment is needed. I will just mention quickly that since this was a model that was really focused on homeless individuals, we use a housing first philosophy, which is where that housing is not contingent on being sober, that housing is a human right, and people need to be housed regardless of what their status is in terms of their use. Okay. So we thought this model would really address all the needs of our client population when we first started the program, but we learned we needed more. So let me show you just a little bit about what our client population looked like with an example. So here's a client, 63-year-old woman, and she has a history of crack cocaine addiction, also schizophrenia, and she has been in and out of the criminal justice system for many years due to many of her co-occurring disorder symptoms. So she's often arrested when she's intoxicated, having an episode. She's also involved in all these different systems of care, right? So at the top here we see the admission team, which is the case manager and the peer support specialist, but she's also is a very medically complex client. So she's receiving services from a primary care provider, a specialty care provider. She has a visiting RN that's helping her with some services. She's a DMH client, so she has a nurse through that. And then she's also involved in supportive housing site, day program, social worker. So you could see with a client like this, and I forgot to mention, she also has a TBI. So all these contacts that she has to sort of keep straight and engage with, that wasn't happening. There was just too much for the client to handle. And I'll also show you how this looks in terms of communication, right? So we have all these different arrows indicating where communication should be happening, but often it's not happening, and the client is left feeling overwhelmed, disengaged, and sometimes stigmatized because people aren't communicating with the client or their other providers. It's a lot for a client to manage. And specifically for these clients in this homeless program, it was the medical issues that were just really very difficult and complex to manage. So what we wanted to do is, okay, we have this problem here. How do we increase multi-system coordination and engagement, and then reduce fragmentation, duplication of services? So we adapted the model. And this is what we often do, even though this is an evidence-based model, we listen to our client population, our settings that we work in, and we really use what we've learned from those populations to make adaptations that work and support the needs of a client. So we decided to integrate a medical care coordinator onto our team. So as I mentioned, our team has a peer support specialist and a case manager who work together, and we brought in medical care coordination and brought in an RN to serve in this role. Okay. The primary care or medical care coordinator really works closely with the case management and peer support team to provide coordination of just medical services because there was such a huge need for that. So she would work very closely with our team to make sure that the client is engaged to medical services, that the team as well is aware of how medical issues really intersect with the substance use and mental health issues. And then she would sort of span different systems, the medical systems that the patient was embedded in, to provide a smooth sort of transition between the medical providers and also the substance use and mental health providers. Another sort of role that she had, because she's an RN, she was able to provide direct services to clients. Although that was her role in this project, going forward, this role will probably include folks who don't have a medical background. So because she had a medical background, she was able to provide some assessment of medical issues and some brief treatment, and then link to medical care and make sure clients were engaged in medical care in the community. Another part of her role as well is many of our clients were disengaged from the medical community and from medical services. So she really took on an assertive outreach approach to her work. She would go into clients' homes, go meet with them in shelters, go meet with them on the streets to talk about their medical care and sort of the overlap between medical care and their other needs. So like the rest of the team, she was really involved in sort of an assertive outreach approach. And we found in our work that assertive outreach is one of the key things to get folks engaged in care, that if you're not meeting clients where they're at, you are not going to get clients to come in the door. So you build it and they won't come. You have to go to them and make things accessible and engage them in treatment. Okay. So in terms of our preliminary findings, what we found so far is that that with this approach, not only have we seen reduction in mental health and substance use symptoms, and also increased access to housing, what we found is there's been a reduction in the average number of days people have experienced medical problems, and also a reduction in the emergency room services for physical problems. So we really had an impact on some of those medical issues. Just really quickly, some challenges, new challenges and solutions that arose as we adapted the model. Role confusion, right? The medical care coordinator really overlaps in some ways with the case manager, but we sort of addressed that by making sure that the medical coordinator was really focused on those medical needs and not focused on the other needs like housing. She might focus on housing as it relates to maybe access to a medical center, but not really spending most of her time on that. Communication. There's a lot of communication that needs to go on when you have care teams to ensure that you all are rowing in the same direction. So we've come up with some tools, communication tools that we use on our team. And last is integrated treatment plans. In this model, what we have decided to do is that we've developed an integrated plan where the case manager, primary care coordinator, and peer support specialist work together with the client to develop an integrative, collaborative case plan that they meet with the client to talk about in the first couple weeks of treatment. And then last is sustainability. This is grant funded. This is hard to pay for, and we're still struggling with how to sustain this model. It's effective, but we're still trying to figure out how can we get folks to pay for services like this. Okay? Thank you.
Thank you, Dr. Gaba, very much. Remember, if you have a question, write it down. You can either ask it later or you can submit that in written format. The next panel member I'd want to introduce is Dr. Trip Gardner. Many of you are familiar with him, with Penobscot Community Health Center since 2004, was previously the medical director of the state of Maine Department of Behavioral and Developmental Services for 5 counties of northern and eastern Maine, overseeing quality assurance, system development, and program development. He's a board-certified psychiatrist. Dr. Gardner?
Can you hear me? Good, good. I'm sure you can see me with my bald head and these lights, so, but I think hearing me is much more important. I'm not much to look at. Not originally from Maine, not even southern Maine, as you could probably tell by now, right? I'll try not to talk too slow. Let me know if I am. Dr. Bersani asked us to give you our insight into 2 of the biggest challenges that we face in doing this line of work. And there's lots of challenges, and there's lots of rewards, and there's ways around challenges. For me, the 2 biggest challenges I see, both from my vantage point of taking care of patients and my other role of being the chief psychiatric officer at Penobscot Community Health Care, where we have 11 clinics that have fully integrated biopsychosocial care, from care managers to counselors to psychiatric nurse practitioners and psychiatrists, and lots of primary care clinicians like my friend and esteemed colleague, Dr. Lochsterkamp here. So the number one thing from my point of view is social exclusion. We know that chronic stress potentiates addiction biologically, psychologically, and socially. Yet we keep trying to utilize social exclusion to help the disease. Clearly makes it worse. We see this in lots of ways. I think we see this with stigma, bias, and shame, which hasn't worked yet. The patients I treat try that with themselves most often, as do the rest of us, I think. We try to treat this illness with gel. Doesn't work. Costs a lot of money. Leads to lots of morbidity. We try to treat this by letting housing become unstable, letting people become homeless. Surely they'll get it if they have to become homeless. Just doesn't work. It actually just keeps making it worse. You know, we can't accept it despite the knowledge. I don't consider myself an expert. I think we have very few experts, or they're very quiet because we're not doing such a good job, right? I heard this morning that only 10% of people enter into treatment. Boy, if that was any other illness, I think we would be up in arms in a much bigger way. I think part of this is we might say it's a disease. I don't think we really treat it like it is a real disease. I think those of us who say it's a disease often don't treat it like we do all the other diseases. I don't think we use the same amount of compassion. I don't think we use the same amount of empathy. I don't think we demonstrate open arm helping behavior that we would for any other chronic medical condition. I think we say, yeah, it's a disease. Now, if we acknowledge it, the next thing often is trying to find a way to get them out of our practice or out of our office. So I think it's a problem everywhere. And I think people with the disease exclude themselves. I think they think that's the way to go. And to me, we have to change that. In the medical field, I think it causes us to miss the obvious. It causes us not to think about the risk of things like opioid prescriptions, as we heard about this morning. We don't think about the contraindications. We don't think about the harm that we can do. We just go forward and not acknowledge. Second thing is failure to motivate people into treatment and recovery, which I think is closely tied to the first thing. There's a lack of hope that things could be better. You heard this morning that the treatment is just as effective as other chronic conditions. Dr. Savage did a nice job laying that out for us. Do you hear that in your own head, and do you hear that outside of this room? Just as effective. Of course, we only get 10% of people into treatment. We heard in the next wonderful presentation, which was about motivation, oddly enough, and I think that is a very important piece that we must look at. There's high cost to the treatment. There's a loss of a stabilizing factor in the person's life in some way that we might not understand. And the benefits are often long-term and not easy to see compared to the immediate benefit that the person who's using the opioid sees. We might not understand how they see that as such a benefit, but we're not necessarily in their shoes, and we haven't experienced it, as we heard this morning too. And the two great presentations this morning, I thought, that nailed these points home. The other thing is we have this rigid one-size-fits-all treatment that we don't employ for any other chronic condition. That's hard to motivate people into treatment. Imagine in diabetes if we had people who said, if you eat a donut, you're out of here. Or we had people that said, keep eating donuts all you want, I'll just keep giving you more insulin. And those were our only two choices. You know, this is a continuum of care disease with a continuum of severity. If we meet people where they're at, we have to expand our thinking like we do in other diseases, where we accept a wide range of paths to the person's recovery and a wide range of outcomes as well. Finally, I think that the social and occupational rewards of recovery have been made more difficult if you have this disease. I don't know of another disease where we make it more difficult to achieve an upward moving social and occupational life than we do that in addiction. I don't know of any other disease, and it's harder than if you don't have the disease, as if that punishment will make the disease better. And finally, there's huge gaps in the continuum. So you have to leap from one place off of cliffs sometimes to get to the next place. And we see people getting worse to get better all the time. So now that we've gotten through the positive, I'm really a positive person. I sure don't feel like it right now, though. Boy, that was over the top. What we've done at PCHC, we've tried to promote a culture that is fully integrated biopsychosocially, where addiction is not separated from any other condition. It's just one of the many chronic health conditions that go hand in hand with the others. It's part of the job like the rest. You can love it, you can like it, you can not like it. It can be your favorite disease to manage, it can be not your favorite disease to manage. It doesn't really matter. It's part of your job. That's what you do. There's not a choice of which diseases you get to treat and which you don't. Again, getting back to this is really a disease. We take a team approach to all chronic health conditions, and we include addiction in that. We understand it takes a team to manage the biopsychosocial needs for any chronic condition, addiction no less, maybe more. We have information sessions with all employees, no matter what they do, the clinical and the non-clinical, that help explain what addiction is, that offer facts for addiction so that they can move forward with their understanding so that we can hopefully reduce the negative judgment and increase the understanding. We address this with employees when we interview them and when we orient them. We finally carry that on with monthly case conferences where we try to reinforce these things. And even then, very difficult. We have increased access to treatment and recovery supports. We have 26 buprenorphine prescribers in 6 different clinics. That sounds great, but we have 130 eligible prescribers. I think we're doing really well. However, I don't know why we don't have 130. Hard for me to understand why we don't have 130. And that's with lots of efforts. We've done lots of things. The best thing we've done is to put Dr. Leisterkamp in a position where he can lead us in this effort, and he's done amazing work, probably doubled the number of prescribers since he's been in that position. He's a model for primary care clinicians providing care for opioid use disorder, and has been doing that since 2004, David? An early adopter, for sure, and he's leading us as we try to do better. We make sure we have care management, case management available everywhere. The counseling is done side by side. Our model is to not segregate in any way clinicians. So clinicians that work side by side, offices side by side. Dr. Loxterkamp and our mental health substance use disorder counselors do group together, he'll tell us. Very important, critical. We have started what we call the RISE program, which is for people who are in jail, which provides a counselor while in jail, along with the jail medical services, evaluating and initiating medication-assisted recovery. And that same counselor remains with the person when they get out of jail. This is a pilot phase project for women only currently, not our choice, but we're hoping to prove that it's effective and move forward from there. We also have recently been awarded a SAMHSA grant for a program we call the WISH program, which is utilizing critical time intervention and motivational interviewing for people who are homeless, combined with recovery coaching, peer supports, and our fully integrated primary care psychiatry counseling clinic aimed at the chronically homeless. The 5 of our clinics do opioid-based office treatment in a traditional mode with success. And then we have a program that is available for daily prescription for people who have either not done well in those programs, but do not want to engage in other programs in the area that may be more stringent, and especially for the homeless who are often not able to be in the program secondary to the risk. So we provide daily prescriptions for these folks and daily group therapy, trying to plug the gaps in the continuum, and there's still plenty. Almost done there. I think one more thing that we do, I just wanted to mention really quick, I'm sorry, is we really think it's important to expect that our prescribers responsibly prescribe controlled substances. And to this end, we've decreased the prescriptions of chronic benzodiazepines and chronic opioids by 70% in 4 years. Yeah, that is good. We're happy. Our process in this is we have a controlled substance initiative team that's made up of a family doc, a pain specialist, a family nurse practitioner, an LCSW, a care manager, clinical pharmacist, and a psychiatrist. And we review cases each week where controlled substances are prescribed, and we offer support in how to best manage the patient from our vantage point, knowing that we don't actually know the patient, but that support seems to be helpful overall. The other thing that we've done that I think is really important is we've engaged the community. We formed a Bangor area substance work group, Bangor area controlled substance work group, that has combined most of the prescribers in the area, the entities that they work for, with their clinical direction, and we have now adopted the same policies and guidelines at each of the entities, so that we're all working off the same contracts, the same procedures, the same policies in our primary health systems, and now moving forward to psychiatry and dental and specialists are our next challenge. So it takes a lot of work, and we're still way behind. So I'm hoping to learn a lot. I already have today. I'm going to learn more here. I'll be quiet.
Got to give the good doctor a break. I mean, he's working with 15-minute appointment blocks, so, 10 minutes is tough, right? Okay, so next I'm going to introduce Jesse Harvey down at the end. Is a Portland, Maine recovery advocate interested in building more recovery-ready communities. He is chapter lead of the Young People in Recovery Portland, the peer support coordinator for Greatland Portland Health, and the founder and director of Journey House Sober Living. Drug use, trauma, incarceration, and isolation brought Jesse to a profoundly dark place. He overdosed with a suicide attempt. Jesse was involuntarily committed to a judge into treatment. In 2015, he was discharged to the Portland Recovery House, where he began to rebuild his life. He is now a very important part of the Portland Greater Health Treatment Team at the Community Center here, Community Health Center. Jesse?
Thank you, Captain. My name is Jesse Harvey. I'm a person in long-term recovery and the peer support coordinator for Greater Portland Health. As I was sitting down this morning, I realized that I looked at the papers and saw the date, and I realized that today makes 26 months exactly since the day that I was involuntarily committed in Massachusetts into a treatment center in a correctional institution. That was the 5th time that I was involuntarily committed. And something happened during my 25 days in treatment that something just changed. I don't know exactly what it was. I've tried to isolate what exactly it was. Maybe it could be replicated, but I guess some questions maybe just can't be answered. I actually wrote a letter to the editor about a year ago advocating for a involuntary commitment mechanism for Maine, for so many folks who are daily putting their lives or the lives of others at risk as a result of their substance use. Just a few months ago, I wrote another letter to the editor, essentially rescinding that letter to the editor. I've developed a much more nuanced understanding both of my personal recovery and of the phenomenon that is recovery. It's been a privilege working with so many professionals who are so dedicated to treating substance use disorder and really encouraging recovery. It's also been a tremendous privilege for me working with peers, people who have substance use disorder or other mental illness and are really trying to find their pathway to recovery. Along the way, I've encountered a lot of personal challenges in my own recovery. I've encountered even more challenges while working with people who really don't have access to a lot of resources, people for whom low thresholds programs really are, we need more of, definitely here in Portland and in Maine. Some of these challenges that I've identified, the shortage of resources that we've all been talking about, and then the gaps in between them. I've worked with folks who have been discharged from a detox and given a prescription for Suboxone to carry them over until they can get to treatment, ideally a day or two later. And then when they show up, they're drug tested and the Librium shows up. They say, oh, sorry, we can't give you anything. You know, you've tested positive for benzodiazepines. And they have the paperwork there with them that says the benzodiazepine in their system is from detox, where they were just a few hours or a day ago. People are sometimes being just discharged into essentially a minefield, and they're expected to make it through to the other end from jail, from hospitals. And it's difficult really to watch. But I think the peer support is about just being with the person on the journey, and they're as much there with me on my journey as I am with them. I'm not really providing any answers. That's not my intention. If they happen to gather some answers from my experience, or if I happen to gather some answers for myself from their experiences, that's fantastic. And that's obviously one great part about peer support, but ideally it's just having the presence there, I think, of a peer, somebody who understands the condition and who also understands recovery. Not all just needles and spoons, but also the other side of it, the recovery as well. Another serious challenge, I think, is stigma and discrimination. I wrote down discrimination because stigma is really just a word that's sort of difficult, I think, to really sometimes wrap. It's been difficult for me to wrap my head around exactly what it is, but discrimination is the end product of stigma. That's what ends up happening as a result of stigma. Systems just aren't oriented as well as they could be to effectively treat people and bring them into recovery and help them to achieve long-term recovery. Another serious challenge is a lot of medical professionals in here, and it's fantastic seeing more and more people becoming ex-waivered or otherwise educated about substance use disorder and capable of really treating it effectively. But the truth is, the medical community really can't confront the issue alone. You know, we need the assistance of law enforcement and the courts, housing first, education, employment, all those things that are really going to give people a reason to not use drugs. You know, when the drugs were just removed from my life, I was lucky that there were other things there to take their place. if offered a horrible life and drugs, or just a horrible life, I would pick the horrible life with drugs. You know, even today, it's it really the only reason that you know, we talk about, one of the slides earlier said it's an irrational, that it's inherently irrational, and I understand that, you know, but then at the same time, the substance use disorder side of me, the person who struggled with that, it just makes total and complete sense to use substances, especially when life is difficult. And then, especially when life isn't difficult, it's like just reward yourself with a substance. But then when life does become difficult, the only thing then that you know is to use the substances. Actually, when I was involuntarily committed, we had these homework assignments that we had to do for the prison officials, and one of them asked me, one of the sheets asked to list 3 hobbies, and I just, all I could think to put down was benzodiazepines, methamphetamine, and alcohol. I had to rack my brain to even come up with anything else, and I ended up putting down things that I'd never done, like gardening and filmmaking, because I couldn't think of anything. Today, I'm pleased to say that I do have hobbies, I have interests, I have activities, I have a community, I have friends, I have employment that gives me a sense of meaning and purpose, and most importantly, I have community. It's the recovery community here in Portland, Maine. That's been one of the biggest things I've been able to fall back on. I think another something that's been kind of challenging is I see a lot of an emphasis on the modality of treatment, whether it's just abstinence or just medication. And clearly, some of those work tremendously well for some people, and others they won't work for at all. You know, I've slowly developed this wider understanding of my recovery and others, that recovery can be abstinence-based, it can be medication-based, it can be meditation-based, nutrition-based, art-based, religion-based, you know, the list goes on ad infinitum. I think the over-reliance on just a few limited sort of tools. I think back to my first overdose in 2011. The discharge paperwork said, you know, you tested positive substance abuse, a word that carries its own stigmas, that the abuse, but that's what it said on the paperwork back then. I wonder if the hospitals changed that language since, but test positive for barbiturates, alcohol, benzodiazepines, heroin, and the suggestion there on the discharge paperwork was go to a 12-step meeting, and that was really it. I wasn't really offered a variety of mutual aid, peer support groups in case that didn't work for me, and that didn't work for me. It actually took until my second overdose that I went and was really captured by those sorts of meetings and began to actually do that work. But that second overdose, actually, I overdosed in a Burger King bathroom, and went outside and was being dragged by a friend to her vehicle because I was on probation at the time, and she was worried that I'd go to jail. Luckily, some passersby called 911, and they came, and I woke up in the hospital. If I had been dragged to the vehicle and brought home and put on the couch, I would have died. It was clear after the fact that my heart had stopped, and lucky for me, paramedics came and intervened before I made it to the girl's car. I went to a psychiatric hospital after that. It was about the 3rd or 4th time that it happened, and a day or 2 later, I was released, just homeless, sort of just to drift around the streets. I don't know exactly what they were thinking I was going to do or where I was going to go. A few months later, when I attempted suicide and was brought back to the same psychiatric hospital, and casts were placed on both of my arms. I was released after 48 hours, again homeless, no discharge plan, still suicidal, At the time, I was really glad that they were releasing me, that they were letting me leave. I didn't want to be there. I just wanted to leave and drink and use drugs. But today, when I look back, I'm curious as to why they let me go, or what they thought I was going to do, if they thought I was going to live or die. Some of the I understand, I was a community health worker prior to the job that I'm working now for about 18 months, and in the beginning of the job, I like to think, why don't people just sort of grab these resources or find the resources that are out there, that are available. Slowly I came to see, obviously, that there's a tremendous shortage, that there are gaps in between the resources. But also, it slowly became reminded of the fact that when I was in some of their same shoes, I didn't want the resources. I didn't want the resources at all. I wanted to just continue to live the way I was living, even if I was miserable. I've talked about a lot of depressing things. I think I'd shift gears a little bit and talk about some happier sorts of things, the real successes, and some of the really positive things that I've seen in treatment and in peer support. Like I said, I've had the privilege of being with people on their journey and being engaged in a process together of mutual growth and learning, where neither one has the answers for anybody else. Inviting really transformative, sort of slowly maybe, but inviting transformative relationships and ideas. Another real positive I've seen is a slow, gradual, but a shift nonetheless towards more destigmatized language among healthcare professionals. You know, if we think of the stereotypical, like somebody who is injecting drugs, you know, if somebody's injecting drugs and maybe they're homeless, they're in an alley, they're at the lowest of their lowest, and if they're labeled, you know, a drug abuser, I've just gotten to a point where that doesn't even make sense to me. It seems like if anybody or anything is being abused, it's the person, you know, either by the drug or by society through the form of neglect. I just can't picture that person as being an abuser. Words like addict or ex-addict, you know, I had malaria when I was 3 or 4, but I don't walk in the room and my doctor doesn't say, oh, hey, so you're the malaria. Another something I'm very interested in seeing is more, besides just the language, is a change in the approach to treatment, that it's not all rules, that it's not all things that have to be done, you know, things that should be done, but really just sort of turning it over wherever possible to the individual. So a treatment contract isn't just 100% rules, but, you know, maybe 90% rules and 10%, you know, a statement on you know, this is your recovery, and we want to be here to empower you to really do it. And besides these rules of ours that you might have to follow, that we'd like for you to follow, a majority of your recovery is going to be based on your own efforts. You know, really challenging people's expectations of themselves and their expectations of the future. Letting them know that there's really sort of infinite potential out there. Yeah, I think I'll leave it at that.
Thank you, Jesse. Very powerful there. Our next panelist is Carol Lee Lindsay, Director of Substance Abuse and Co-occurring Services with Catholic Charities Main Counseling Services and St. Francis Recovery Center. She's worked for over 30 years in social services as a rehabilitation counselor, social worker, clinical supervisor, and service director of substance abuse and co-occurring outpatient and residential programs. She has a lot of leadership experience in this field, and looking forward to hearing from you, Carol Lee. Thank you.
Thank you. Can you hear me? I want to thank everybody who has spoken here today, the presenters and the panelists, and I'm always eager and anxious to get new information, to learn, to figure out how I can take what you have and maybe adopt and adapt it in my setting. And I often do also sit with program envy, because when I hear, oh, the hospital pays for this, you know, it's really difficult for those of us who work in a nonprofit situation where we depend on federal funding and we live in a non-Medicaid expansion state. And, you know, and I've watched this over the period of time make the challenges even more. Before I continue down that road, I think most of you in the room are probably familiar with Catholic Charities. We do have the outpatient program in Portland. We've worked a lot over the last 15, 17 years with the criminal justice population, even before that, but we've worked with the drug courts, the federal drug courts. We work with the federal probation offices, and we work with the Bureau of Prisons. So we get a lot of folks coming in that avenue. We also get folks coming in from the homeless avenue, the Milestone. And up at St. Francis, we have another level of care, which is the men's residential program, which is 16 beds. We also do drug courts up there. So our focus at Catholic Charities over the years has been to figure out how to do this treatment thing with, you know, not just folks who are addicted, have substance use disorders, but also have been in and out of the criminal justice system. And, you know, some people get there a little bit as Jesse has described, but then some people, you know, have a longer-term criminogenic background. And so, you know, chicken and egg, sometimes it doesn't matter, but it's what are the treatment modalities that are going to be effective. I'm going to come at this a little bit differently, and then I'm going to talk a little bit about some of the challenges. When I was thinking about this presentation, and thinking about, opiate in the primary care office and a community approach, and have spent, the number of years that I've been in the field reaching out to other stakeholders, other providers, doing grant collaborations, talking to folks about how can we work together, how can we build this. What's happening, which I think is great, is this whole other approach with it coming out of the primary care offices more and more, and I think that's wonderful. And I sort of look at, well, sort of what's our position now in terms of having been the old school community provider. And I know that there's a role and there's a position, and I'm in conversations with some of the folks in the room, with the Portland Healthcare and Milestone. We've made a presentation to the state about a collaborative approach of bringing people from the Milestone detox into treatment, getting into primary care. We'll see where that goes. But what I was thinking about a few days ago, when I was out for a run, actually, which is where I do my thinking, was we've been through some pretty intensive meteorological events recently in our country. So I'm thinking, like some of you, maybe you watch this hurricane stuff on TV, it's like there was nothing else in the world going on except for, Hurricane Irma, at least according to MSNBC and CNN. So a metaphor came to me, and this connects also with what we heard today about the tobacco. We have more people dying of tobacco disease, if you will, complications of that, than we do of this crisis that we're in, which we're definitely in the opiate crisis. But what the opiate crisis is a little bit about the end stage of what we would look at in terms of tobacco. So if we know tobacco takes a long time before it kills somebody, I think we have to recognize that there are other components connected to why we're at this crisis right now. So the metaphor is this. We've been through the meteorological events of the hurricanes. We have all learned from Irma that the integrity of the system was maintained by the pressure, cohesiveness, and stability at its core. the eye. For the hurricane to generate the power it did, the energy had to stay constituted around the center. We have no unifying force in our policies and compassion toward maintaining a healthy and functioning center in our society. If we did, we would gear resources toward families, early childhood development, education, healthcare, vocational opportunities, sustainable wages, and affordable housing. We would approach the opiate crisis systemically. The cities and Floridas that learned from previous hurricanes, such as Andrew, built the infrastructure and developed the emergency preparedness to deal with and address the next challenge. Metaphorically, we have done the opposite regarding mental health and addiction. We're kind of making a turn back, but I'm experiencing some of the wind shears in terms of where I work. So these things don't occur in isolation, but they're symptomatic of a culture that lacks the energy, compassion, social justice, equal rights, and shared responsibility. We hear a lot about things like, you know, it's race, place, socioeconomic injustice. You know, I just told you the population of the folks that I work with, and by and large, that's what we're talking about. You know, I think of things, you know, this also came back to me is in my social work training. Of course, so this is why I think of macro issues, because there's the social worker in me first. Stanley Greenspan was a child psychiatrist, and he was the former director of the Clinical Infant Development Program for NIMH years ago when I was doing social work training. And a quote from him, and I went back to one of the best books about addiction and treatment and all of that, I'm sure you're familiar with, is Gabor Mate's In the Realm of Hungry Ghosts. And the quote is, "If our society were truly to appreciate the significance of children's emotional ties throughout the first years of life, it would no longer tolerate children growing up or parents having to struggle in situations that cannot possibly nourish healthy growth." All of what we are hearing here today, I think there's some wonderful, wonderful things going on, and I actually avail myself all the time of what people are doing. That's how I met David. He came over to my shop in Auburn, and then I went up to his shop in Belfast, and you know, I want to know how people are doing things and how I can do it better, because when I was asked yesterday at a Council on Accreditation review by the reviewer what works, because I'm a dinosaur, I can say, I don't know. I couldn't have said that, you know, 10 years ago. Now, that's not entirely true, because we heard today some of the things that do work. And one of the things that I answered ultimately was, well, what works is when we treat people with dignity and respect, and when we treat them with kindness. So I know that much. It's just a matter of how to bring all these other things together. In the interest of time, I want to talk about a couple of the challenges, and they're the challenges from where I sit in terms of the kinds of work that I've tried to do in the programs. I have spent the better part of my summer trying to chase after money and funding streams and all of this stuff in order to sustain the work. You know, I'm going to further the metaphor a little bit in terms of some of these wind shears. And, you know, those of us who are paying attention, and people who know me know I can't not be political, unfortunately. But it's all political. And, you know, when we read in the newspaper, and we've lived, you know, 7 years under the administration that we have, and all the successes that they have touted in terms of, you know, reduction in funding here, there, and everywhere. One of the things that we know that has happened is that we have, as part of the result of reduction of the SNAP program in the state of Maine, we have increased food insecurity by 27%, 27% in the last decade. So now we have 16% of households in the state of Maine who are food insecure. These are people who have their primary focus, how are we going to feed ourselves today? These are people that I've talked to my daughter, who's a kindergarten teacher in Wyndham, who's brought food to school to give to some of these kids, you know, because they can't concentrate. These are also kids who come out of these homes where other things are falling apart, where there is the trauma, there are those other psychosocial factors that impact, and therefore the proliferation of abuse. So I just am postulating a little bit that some of what we're experiencing is a little bit like the end stage of the disease process. It didn't come out of nowhere, and it's not about more treatment, you know, and what I like to say to people, I'll alarm you, but it's like, it's WTF. What's the function? What's the function? You know, and the function of using drugs and alcohol and all of it has a purpose. And it has a purpose in this biopsychosocial place in which we live. All right, so challenges. Acuity of population and lack of sustained infrastructure in those other Maslow arenas that, you know, I was addressing. Funding for treatment programs and training. Again, I've spent all summer chasing after funding. I wish I could tell you I had a whole lot more of it. Across systems, pockets of cracks, of clients falling through the cracks. So this is, again, the proposal, and, you know, this was addressed, Dr. Gardner addressed it. We're talking about it. We're talking about it by having those low barriers. So this is one of the proposals that was made to the state of Maine that I did on behalf of the Portland Clinic and also Milestone. We're hoping to, you know, be able to have some things in place where we can make sure that people get across those systems rather than getting lost along the way. Creative collaboration, creative and effective collaboration across the systems. I don't know about you, but it's not only time and money constraints, but it's the administrative burdens. You know, when we have to spend so much time doing all this stuff, and I'm sure some of you are more than thrilled about e-scribing in here and how much attention that takes away from patients. And we have a system that's not talking to the other system. It just goes on, okay? Those are challenges. Policies made and driven by folks who don't have boots on the ground. That sticks in my craw really, really hard. So, it happens. I've spent a lot of time building the best practice and infrastructure and one-stop shopping, which I think is moving towards a solution, is that comprehensive services in one place, one-stop shopping, as much as you can, or those warm handoffs, are some of the solutions that we need to have. We don't need to dismantle that because we've decided to, you know, take the funding sources and put them someplace else. We need to be cognizant of what it is that we're taking away. And then collaboration and communication among stakeholders and teams, and not competition. You know, some of how we've been set up in the state is to compete against each other. You know, we need some of these other things. I mean, I could go on too, because if you read in the Bangor Daily News on September 8th about the $8 million that LePage said that he might not take for vocational career training. I mean, there's another piece of that infrastructure that we need in order for things to work. So I will stop there. Thank you.
Thank you so much. Last, but definitely not least, Dr. David Loxterkamp. He is a founding member of the Seaport Community Health Center, which participated in the National Demonstration Project 2006 to 2008 and the Maine Patient-Centered Medical Home Pilot. Earned his NCQA Level 3 certification as a patient-centered medical home, and in 2012 was named Best of the Best Medical Practice and Physician in Waldo County. Dr. Loxterkamp, thank you for joining us.
Thank you very much. So I want to thank Carol Lee for suggesting me for the panel. I like to talk, so I'm happy to be here. I want to thank Tripp, too, for saying everything that was important for me to say. I don't have to say it now. I can just say ditto. And I also want to say, you know, it is a bit of a mutual admiration society between us. We're really, we're two peas in one pod. The peas are a little far apart in that pod, and what we find most interesting about each other is where we disagree. But I think it's critical in this work and really all of the work, especially the work of primary care that I have done for 35 years, is to feel like you're well taken care of so you can focus on other people's problems, which is why we're here, and not have to complain and not have to be distracted, but really focus on what we're really here to do. I'm going to just, I'm not going to talk about the smaller issues. I have kind of bigger worries in my mind when I show up to work every day. The smaller issues I don't worry about, especially when I think about the lives of those I care for. If I ever need reminding, I just have to ask that most important question, which is the first one I ask anyone who enters our program, our recovery program, and I sit across from them in the exam room and I say, how did a good person like you end up in this room today? And they tell me stories, you know, I don't want anybody to have to say or tell. And these are my neighbors and this is my community. So I really feel I don't have worries, and so I'm going to worry about bigger things. One worry is this. I worry that efforts to expand MAT will focus too much on buprenorphine and too little on everything else that patients with opioid use disorder deserve and require. In 2000, as has been mentioned, in 2004, I came to, rather in 1984, I came to Belfast, Maine, from west of Westbrook. This is your southern Maine. I'm west of Westbrook. I came from Iowa with my wife, and we set up practice. I set up practice in Belfast, Maine, and practiced really for the first 20 years like my father had before in Iowa. He was a GP. I was doing pretty much the same stuff, taking care of the same kind of things, feeling just as good about the work I did as he did, until a young woman entered the emergency room in 2004. I was certain was suffering from viral gastroenteritis until she whispered to me, I'm withdrawing from heroin. And it rocked me. It changed me. This was the daughter of a good patient of mine I'd known for years. Couldn't imagine this happening, and I couldn't imagine that I knew nothing about what to do. So for the next many, many years, from 2004 on, we've been trying to figure out how we can be helpful for those who end up in our office asking for a certain kind of help. Then 6 years ago, as my small practice was looking around to get a little help with administration, dealing with insurance companies, that sort of thing, we approached PCHC. I thought they were going to do all that for us, and they did. But what they really did was change my whole conception of what primary care was. In our little office, we knew that we were being inundated with patients who had many different kinds of needs that I had no capacity to deal with. No way to help them with their mental illnesses, really their serious mental illnesses, no way to help them with their homelessness, their lack of money, their problems with transportation. The more we expanded our opioid use disorder program, our recovery program, the more overwhelmed I felt about providing the real needs that they presented for and the real obstacles for their getting better with their lives. And so in joining PCHC, we all of a sudden built out this really amazing clinic whereby we now have 3 behavioral therapists, a pharmacy, physical therapy, care management, nursing education, and of course prescribers for buprenorphine and primary care that people can access. This is so important for us because, well, one of the biggest obstacles in getting people to our practice is that we care for people from 25 different zip codes. So if a car breaks down or they don't have public transportation available, because we're in Belfast, quite a rural area, it presents a huge obstacle. We had to remind ourselves that 85% of our patients work full-time or part-time, so we had to think about moving our group meetings not in the middle of the day when it was convenient for us, but at 7:30 in the morning and at 5 o'clock in the afternoon when people could actually come. We had to remember that 19% of the patients in our practice are self-care, and this is expensive treatment. To ask them to come week after week, month after month, sometimes years after year, to get the help they need, it's expensive. And so how can we, through care management, we're able to find the resources that they absolutely needed. As was mentioned, it's a multiplicity of problems, and smoking is a big part of it. 80% of the patients in our recovery program smoke. And for many of them, it will be smoking or the complications of smoking that cost their lives, rather than the disease that we feel we can help them overcome. So for all of these reasons, primary care is really now about taking care of all of these needs. When I imagine what primary care is, I think of a three-legged stool, of which I'm one participant. I'm a prescriber. I'm a primary care physician, but social work and behavioral therapy are equally important in the work I do, for sure. One of the things that you learn with co-location of services like we have is that integration's a whole nother story. Getting people to talk together, work together, play together, communicate well, is absolutely essential, not only because we have so many moving parts and so many disparate needs, but because we need each other to reassure ourselves that we're doing a good enough job, or to challenge each other to do a better job. One of the most important people on our team is actually a pharmacist. Melissa Carr is an incredible pharmacist. She does all of our pill counts, film counts, and she's in charge, most importantly, to my mind, she's in charge of the hepatitis C treatment program at Seaport Community Health Center. We've had 59 patients who've either completed treatment for hep C, that has been curative treatment, are in treatment, are awaiting prior approvals, or have been identified as in need of treatment, and 60% of those come from our recovery program. Even though we're a complete primary care office, our recovery program really has these very critical needs for hepatitis C. So, I think most importantly, I worry that as we expand MAT, as we need to, as we must, that we also focus on all of those other things and knit together, if not in the same office, through a network of like souls, of like minds, that we can provide all of the services that people really need. Otherwise, these programs, people leave, people fall apart, they drop, they're lost to follow-up, that common term, they're lost to follow-up, and we worry about them. Because in our group therapy program, we get to know them quite well and miss them terribly when they're gone. The second thing I worry about is this. I worry that we are focusing too much on treatment and not enough on outcomes. I think Jesse will probably, I hope he will agree with this, that being in treatment is not necessarily being in recovery. And being in recovery does not necessarily mean that you're in treatment. They can be quite different things, and we can pride ourselves on expanding our treatment to patients and have no idea kind of what really is happening in their lives or what the long-term outcomes are. Doctors are very good at prescribing medication and billing for services, but we've left it to others to worry about efficacy of our treatments. Chronic disease treatment must look like other long-term outcomes, must look at long-term outcomes, yet most of our studies have lasted for 6 months or a year. So there's really a deficit in how we look at this chronic disease. Like any other chronic disease, we need to measure it and follow it like any other chronic disease. So if we were to do that, if we really to do that, we might ask these questions and answer them actually. Is the occasional or even regular use of marijuana helpful or harmful in the treatment of OUD? Do patients do better in group therapy or individual treatment, and what should these therapies look like? Should we prescribe buprenorphine like we do every other medication, especially opioids, at its lowest effective dose? And if so, how do we determine that dose? There's a ton of other questions just as important, not just the ones that doctors and therapists come up with, but also patients come up with, that we need to begin to answer. And so I guess the real reason why I said yes to Carol Lee and this panel today is to make a little plea to all of us. Maine is a small state. We're not big. We know each other. We're all neighbors. Why can't we be keeping track of a database, a registry, a sense of the outcomes of the things that we do? What helps and what doesn't help? what are we working towards as a large community, this community of Maine? What information should we be documenting? What reports should we be drawing? And how will we react to that information that we accumulate? The way I've always taught and practiced is, well, I better do it myself first. And so in our practice, we keep track of data. And it's really important to do that. Tripp and Company at PCHC has allowed me to participate in expanding that very same database to all the practices at PCHC. My hope is that in working with Central Maine Medical Center and their residency program, as they look at beginning an MET program, that they'll also adopt a similar set of a similar data set so that we can begin to track what really helps and what doesn't, and over the long term, where are patients receiving the most that we can offer them. So I want to end there. I'm happy to talk a little bit about the way we run our program, but I really wanted to emphasize those two things, that buprenorphine is just one piece of a very, very complex and, to my way of thinking, very rewarding puzzle. I've never felt more alive as a family doctor than in doing all of the work that's important for my patients, all of the things that they need outside of what I was trained to provide as a resident. And I hope that somehow we can find a way to work together, not just to treat, but to also consider recovery as our goal and how to help our patients achieve it. Thank you.
Okay, thank you to all of our panel members. That was great. Multiple perspectives there, multiple levels of expertise. I've been promising all day that I wanted to include the audience in this day, and we got about 20 minutes left in this panel. Please, if you have questions, Erico's got a microphone. Kate's got a microphone over here. I've got a couple questions that people submitted throughout the course of the day, but I want to hear from you. So let us know. And if you have any cards to submit, let me know.
So I guess I'll start. My name is Allison Webb. I'm a public health professional, so thank you very much for your comments. Sorry. There you go. I worked at Maine General for a few years, and while I was trying to figure out what makes doctors tick, because it seems to be different than the rest of us, I did read an article about adoption of new procedures, and maybe this isn't 100% accurate, but basically what the article said was it takes physicians 15 to 17 years to adopt a new procedure or a new method of doing things. And so 2000 is the year that we can sort of mark as the beginning of buprenorphine prescribing. We're now at 2017. And so my question to you is why do we not have more prescribers in the state of Maine who are prescribing to as many patients as they can? That's number one. Number two, the rest of that question is, do you think that that lack of doing what's evidence-based has anything to do with stigma, both on the part of healthcare providers, but then also just sort of institutionally, where we just don't treat people who have a severe substance use disorder as well as we treat other people?
Any one of the panel members want to take that? Dr. Gardner?
Sure, I think Dr. Losterkamp would be great with this one. Do you want to go ahead so I don't?
You start first, and as I always do, I'll be on your tail.
Thank you, sir. So two parts to that question. Great question. I'm very frustrated by the same things I think you are. From my point of view, we simply don't see this as a disease the way we see other diseases as diseases, even if we say we do. And it's almost worse to say you do, but really not, because then we don't have a chance to talk about it, right? So I think there's a lot of that going on. I think that's going on throughout society, and doctors are members of society like everybody else. I don't think we've made that turn, despite all the evidence. There's some need to have stigma and bias, and I think it exists in things that we fear we can't control if we admit that we're not necessarily in control. And the brain for me is the Captain Kirk of the starship, and I don't want anything messing with my Captain Kirk. So if I admit that diseases of the brain, that I can't see actually are there, just like diseases that I can see, then I have to live with that anxiety and manage it. And I think doctors are the same way, and they confront that on a routine basis, more than most people maybe. So I think that makes it difficult.
I would add a couple of things. One of the slogans in our recovery program is that recovery is a willingness to change. And if that were the case, very few doctors in recovery. There is an unwillingness to change once you think you have your practice down. I also blame people like myself. I blame myself for not being more outspoken about the importance and the value personally to the work we do in recovery. And I'm trying to make that up now by getting involved in residency education and other things. But those of us who see the value have to be advocates for it. And I think one of the most important places to make a change is in a residency program where you're training the people who are going to be doing the work. If they don't see it in residency, they're much less likely to do it when they leave their residency. I would say lastly, we really have to change the culture of practice and of medicine. That is, we have to see by example and by teaching this that all of this is our job. There's none of it that's not our job. In our practice, the expectation is when you come to Seaport Community Health Center, you're going to be a prescriber. You're going to be involved in recovery work because if you're involved in diabetes or congestive heart failure or hypertension treatment, you're going to do this work. And because everyone does it, it's not a burden on anyone. In fact, it's something that brings us together. It's the one thing that brings us all together in a practice. The culture needs to be one of mutual support and common need and common ground. And not to say my work ends when I leave the office, but this is my community. You know, Belfast is my community. What hooked me was when I saw a neighbor in need in a way that I couldn't help, and no one in the community was prepared to help. We knew we had to do something. And fortunately, I had a colleague who was willing to jump on board, and through that, we just built this as an expectation. This is what we do as primary care doctors. This is who we are. Makes you feel pretty good when you can help somebody for whom no one else has helped, or at least make that attempt, reach out. So I think we have to definitely be advocates, all of us who feel strongly about this. We have to be involved in training programs where the young doctors are learning their skills and their life practices, and we have to change the culture of medicine.
If I could say one more thing.
Sure.
I think it's important to realize that primary care docs and nurse practitioners and PAs, they're generally the kindest, most compassionate, most giving of all the people in the healthcare field, in my opinion. The people that I went to medical school with that went into primary care, they were the people that I looked up to as being special, kind of like the angels in the room. What they're asked to do in our current system is unfair. So when we ask them to do one more thing, whether it be this or look for trauma or try to help diabetes better or treat depression better, we ask them to do that in 15 minutes. So they're asked to provide the most comprehensive of all medical care in the least amount of time. So I think that's a bigger issue. I think David would agree with that, and David doesn't make that excuse. That's why I wanted to come, because I knew he wouldn't do that. But that is a big deal. So we have to fight for primary care providers to have the appropriate amount of time and not let the system continue to spiral in the negative direction that it's going.
Indeed, and we see that from the federal level too, you know, just continuing to add on to what primary care does. Not to say we don't want primary care to be totally involved in behavioral health, but it is just another huge aspect of the work, and so we're trying to continue to give resources for that. Go ahead.
I wanted to thank the panelists and speakers as well as the organizers. This was, for me, very informative and inspiring. My question is for Mr. Harvey. This one's a little less open-ended. Where can folks in the Portland area go to access the mutual aid and peer support that you mentioned and talked about?
Yeah, so actually there's spread out across Portland are several places where several different forms of mutual aid peer support groups are available. Luckily, 12-step groups are just sort of abundant any time of the day. Really many churches and other places all around town. The Portland Recovery Community Center is sort of a bedrock for recovery in this community, and they're open 6 days a week, and the 7th, I think, as well, and offer, in addition to the 12-step groups, offer smart recovery, all recovery, meditation meetings, Reiki, all sorts of amazing things, including telephone recovery support done by peers, so it's not so much a group, but it is peer-run. Other places in town, Amistad, the peer-run social club, they have a lot of groups there as well, including not substance use disorder specific groups, but groups such as DBSA, Depression Bipolar Support Alliance. There's also NAMI groups, National Alliance on Mental Illness, that occur in some places throughout the city. But yeah, the first place I'd say is the PRCC. They have a pretty good offering of things, as well as hopefully lists of some of the resources available elsewhere.
Hi, my name is Joanna. I'm not an expert on anything, so pardon my terminology. So I come from different cultures, and I've been treated in different cultures. And in one of them, I think they have a very different approach to pain management. Not all types of pain are going to be, you're not going to be given a medication for all types of pain. And most of the time, the doctor will be like, oh, I'm sorry to hear that you're in pain, but go home, and then they'll just send you with a pep talk. And being treated here was very different in the way that pain is almost like a disease itself, as opposed to being a symptom. And coming from a family that has a long history of addiction, I'm very always really scared of taking medication that might make me addicted to something. So I guess my question is, are all types of pain, do they all need to be managed? And if some do they need to be managed by opioids? And do doctors go through the patient history to see if they have a history of addiction in their family, since we know that addiction is genetic?
Prescribing fellows, would you like to, not that all pain needs to be treated with medication, but that sometimes is the combination with behavior therapies.
Well, there's a long history, not a good history of doctors approaching pain with one remedy, and that was opioids. In part because of, there are a lot of contributing factors, and there's many books written about where we went wrong in the treatment of chronic pain. I can say now it's completely different. In approaching a person with chronic pain, one of the last things we think about is opioid use. I wish I had done this experiment in my office, but I didn't think of it in time. When we hired 2 physical therapists to join our practice, I felt almost instantly that we wrote half as many prescriptions for pain medication or muscle relaxants or nonsteroidal anti-inflammatories, half as many referrals to orthopedists, and ordered half as many MRIs and CT scans. So physical medicine is a wonderful modality. Many times this is emotional pain being expressed. I mean, so oftentimes in primary care, what a patient comes in for is not what they leave with if we give them time to talk, if we listen to them, and they can tell us about their life, and they can tell us about the troubles they're up against. Once in a while, we will send a person to a pain management specialist who does the same sort of broad look at the context of this pain. When did it start? What aggravates it? What has been tried? And so, again, the last thing tried is opioids. And if opioids are contemplated, We certainly ask about, or we should, I think most of the time we do now, ask about a history of opioid use disorder or other kinds of use disorder. And we do a PMP. We do a prescription monitoring program report to see where else they might have been going to get their medications and what medications they're using that they may not be telling us about. So I think things have kind of really flipped. Certainly the work done at PCHC with reducing opioids that oftentimes ended up in other people's hands, not the person for whom they were prescribed. All this is just part of a major transformation, a really encouraging transformation in the way we think about pain and the way we respond to it as clinicians.
Dr. Gaba, I had a quick question for you that was submitted. Oh, yeah, sure.
Answer that question.
Please.
Although it wasn't part of your question, you really brought up a really interesting piece that really needs to be integrated into treatment, which is culture. So you mentioned that you're from a different culture, and I do encourage folks in the room really to think about culture when they conceptualize the work that they're going to do, when you're creating treatment plans, when you're working with clients. And in line with culture, also thinking about strength-based approaches, strengths that cultures bring around treatment and healing and recovery. So I just wanted to highlight that when you were talking, just popped up.
If I could really quickly want to let us get to the next question, but just an experience that I've had. In 2014, I fell 30 feet. I broke my neck, my legs, my wrist, and I was prescribed all sorts of opiate and other painkillers. And for over a year, I was in a lot of pain. And I remember when I first got to Portland, walking the day after I got here, walking about a block or two, and the pain in my leg I thought was so unbearable. I just remember thinking, how am I going to do this? You know, how am I going to make it? This next couple months or years in Portland without drugs. I was particularly struck by what Dr. Savage said in her presentation about the physiological sensation of pain being filtered through psychosocial context to result in the sensation of pain. Today, I don't even think about the pain that once seemed so real and so unbearable. My leg gives me a little bit of trouble when I wake up in the morning, or sometimes after a long period of laying down, I get up and it hurts, but 99% of the day I don't experience any pain, and I don't take any medication for the pain.
I have one written question for Dr. Gaba. You mentioned that your program was manualized. Is that accessible to others? That was one question that was been.
And our last slide had our information on it. But if you go to missionmodel.org, our manuals are free for anyone to download. We also have consumer workbooks, which are a great companion as well to our manual. And we have a version for working with clients who are homeless, a version for working with clients who are veteran population, and then also a CJ version. So I really do encourage folks to use those free resources. And we have tons of other resources on our website that are free to folks.
Carolee, a question for you. If you were to see an increase in funding, where specifically do you think that is needed from your perch?
One of the things that we started many years ago in Portland, I've had a psychiatrist working with me in Portland since 1995. I've had prescribers for medication-assisted treatment since probably 2008. So I have built that in, and I've built in the continuum of care kinds of things. What I'm particularly intrigued about is the fact that we do have primary care really stepping up. Again, even in 2008, when I was working with before I had a prescriber in-house, I was going to folks outside and trying to get the psychosocial treatment component because they were prescribing, but they weren't offering any treatment. So what I would do is I would continue to build those collaborations. I don't know if there still is a place. We've evolved in terms of how we've done treatment over the years, and I would like to see where the place is that we would most appropriately fit. But I think it's in this collaboration. So the money that would be used to develop the linkages to the Portland healthcare and to other places like Milestone that I've talked about It would also be looking at some of these models, perhaps the mission, the model that we were looking at is called a link model, which has the warm handoff. It would be providing, access to some of these. We're being held accountable in some of our contracts from the Office of Substance Abuse this year to, investigate whether folks have vocational needs, whether they have housing needs, and to, give them information about how to get that, some support around those. It would be creating that so that could come on board. We've done some of this with partnerships in the past, collaborations with the Cumberland County Sheriff's Office and some Maine pretrial and Goodwill, where we had a reentry program from the jail. So it'd be building more of these, but having them with some sustainability over time.
Thank you. One more question, yes.
I'm curious about what your perspective is about the use of medical marijuana. I've been a nurse practitioner for almost 30 years, and I think about the waves that we've gone through in terms of, way back, don't prescribe opioids, and then there was a push that we weren't treating pain adequately, everyone should be using opioids, and then we're away from that now, and I feel like there's almost a movement to use medical marijuana to treat pain, and I'm wondering if 10 or 20 years from now we're going to find out that we've created yet another monster. And I'm wondering what your thoughts are about that.
It's an unknown, and we do create, unwittingly we create monsters. There was just a couple of articles, I think it was in JAMA Internal Medicine, looking at marijuana in the treatment of chronic pain and PTSD and finding no long-term benefit in either situation. Much of what we do in recovery work is anecdotal, and unfortunately, we do need more data. So I wish I had an answer, and I share some of your concerns. It's not that I am completely... I think probably marijuana ultimately is safer than the cigarettes that patients are smoking. We don't seem to worry quite so much about that, or have success in treating it. But I share your worry. It may be helpful, but we don't have the data.
Okay. One more, Erica? You got one?
When I was in graduate school a couple of decades ago, 3 or 4, there was shootings in Compton, and not much was going on around that until we had shootings in places like Newtown, places like Colorado. And I can't help, as I'm listening to everybody today, and I think it's been wonderful, the struggle in my mind throughout the day is, why is this not a health crisis? And from my perspective as a white girl, growing up pretty middle class, this is the drug problems have been in the inner cities and in the minority communities for so long, and it was treated as a legal problem, a criminal problem. And only when it starts hitting towns like Falmouth, my town of Cumberland, the suburbs of Boston where I grew up, I think that institutional racism has not been talked about today. But institutional racism, I think, is what I'm looking at in my own mirror today. And I think until we all come to terms with that, how we view what a health crisis is, what warrants a health crisis. I don't think this is physicians taking 17 years. I think this is all of us taking a moment to stop and get very mindful about how we view each other.
Thank you for that. Very important point. Thank you. I think we'll end with that. What I'd like to do is say that if you did submit a question, there's a couple questions I didn't get to here you'd like a response to it, I'm just going to leave these up here. You want to put your email on there if you submitted one and you did not get an answer today. And same goes with anybody who has additional questions that were not able to be addressed verbally. If you write them down on a card, give us your email. We will be in touch with the experts and get back to you on that. Thank you all for your participation. Thank you to the panel. Great job. Appreciate it.